Welcome, everyone. I'm Dick Deming, Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our guest this evening is Dr. Arif Kamal. Welcome, Dr. Kamal. Dr. Kamal is the Chief Patient Officer for the American Cancer Society. He also happens to be a medical oncologist, a palliative care specialist, and a friend of mine. So welcome, Arif.
Thanks, Dick. Thanks for having me.
Yeah. So we're going to talk about a lot of different things, but before we start talking about cancer in America and in particular the role of the American Cancer Society, let's get to know you a little bit. So I already said you're a medical oncologist and a palliative care specialist, but how did you start your career in medicine?
Yeah, I grew up in a small town in rural Missouri, about 15,000, an hour and a half east of Kansas City. So people in Iowa probably know kind of roughly where I'm talking about. And I originally thought I was going to be a litigator, a lawyer. And, kind of overnight that changed when my mom was diagnosed with breast cancer when I was in high school. And really, as my, journey through that has morphed and changed, I really learned a lot about the experience, not only for the patient, but their caregivers, their community around them, and what goes well, what doesn't go well. And, I've fundamentally made my career about helping people achieve more good days. And both of those things are important to me. More days longevity is really important to a lot of people. But when I talk to my patients, the life in those days, the quality of life in those days, the experience, what makes a really good day for someone ends up being oftentimes what we spend a lot of our time talking about and what people value. And so for me as an oncologist, having to go through that journey with her, and then ultimately she succumbed from that journey, and so it was a formative moment for myself and my family to understand the limitations of science and kind of where things were at the time, and gives us perspective on where things are today, and some things still remain true about the challenges of the experience and so on, and so. My calling was then to actually understand palliative and supportive care. So also for people who know Iowa, they know it's close to the Mayo Clinic, and that's where I went and did some training in palliative and supportive care. Actually, as one of the first ever palliative care fellow at Mayo, and one of the first in the country to really bring intentional training and a skill set around this idea that we can support people's quality of life by understanding the drivers that facilitate their quality of life and the things that get in the way. Everything from spiritual issues and existential issues to emotional, physical, relational, logistical, financial. And so putting all that together around a person to understand the person as a whole person is really kind of that skill that came through in that training. And then did oncology work at Duke, and have practiced for the last 15 years, really starting the outpatient supported palliative care program at Duke within the Cancer Center, and being a breast cancer doc as well. And so seeing kind of how we can give people the right treatment, but also support their quality of life during that period of time, that there's really a false choice between the two, that we can live well and live longer, has really been the thesis of my career. And in bringing that to ACS, to the American Cancer Society, really with a wonderful team around me, focusing on how we express those values into programming that we do to help people across the country.
Right. I think a lot of people think about the American Cancer Society, and I think people generally know what it is, but I think people have have some misconceptions about the work that they do, and they think that most national cancer organizations do a lot of research.
Sure.
American Cancer Society does a lot of research, but American Cancer Society also is deeply involved in the practice and the standards and guidelines and the work that we cancer doctors do out in the field. And I think a point in case is just your title being Chief Patient Officer is a title that implies or directly states you're interested in how our patients actually getting the care out in America. Now, it's not a administrative bureaucracy where all of us cancer doctors fall in line
Sure.
and report up to you. But how do you view this role, and how would you describe what it means to be the Chief Patient Officer?
Yeah, and when we think about healthcare and the challenges that it faces, oftentimes it's because the design of the facilities, the processes, and so on, didn't bring intentionally to the table all the people within that process. And importantly, as I think about the end user for healthcare, that's people with illness and their caregivers. And so I think it was really important that as we thought about the future of the patient services that we do within the organization, that we always are very mindful, whether through title and role, of what would a patient say if they were in this room while we're doing strategic planning or a budget exercise or deciding between this or that. What would a patient say? How would they respond to that? And I think that you know one, I take that very seriously. I was in clinic today, earlier today, right? Seeing patients. And so channeling the like, if I put this idea in front of the patients that I care for, how would they react? And that's important. But also, we have a patient and family advisory council, not dissimilar to cancer centers have, right? That really genuinely want the input of their community members, former and current patients, caregivers, the bereaved, et cetera, to provide not only insight but a litmus test, sort of a like, that makes sense, I'm not sure that makes sense. We have one of those for the patient support work that we do as well. And so I think it's really being more inclusive to ideas and opinions and thoughts, and I think that's what the role has really been. And I can tell you that I think, we've had to, like any large organization, nonprofit or otherwise, has to make really important decisions about what it values or not. And in what's the ultimate North Star when two things might seem about equal and you're trying to pick one way or the other. I think it's helpful that you've got patient support as a business unit, you've got a chief patient officer that, that in that room, you've got, right, the literal representation of who we're trying to serve and whose lives we're trying to make better, so that if there's a tie, I think the tie always goes to the patient. And I think that's really how we've been acting. And I think it's the reflection of the values of
Mhm.
who support us as an organization, donors, volunteers, and others. That's, I think, what they expect from us. And so it's the literal, living our values in the work we do.
So, all of America is shifting the way they do work. The role of doing things virtually, the role of apps, of the web, even AI has affected the way we do work. And it's clear that it's also affecting the way the American Cancer Society does work. So, American Cancer Society for decades has had patient facing programs
Yes.
such as exercise programs for women who have come through mastectomy, for
Yeah.
getting rides for patients to come to the hospital, to having products available, a catalog for a look good, feel better. You have rolled out three new programs,
Yeah.
and all three of them are utilizing technology in a way that's different.
Yes.
Because it's more readily available. So let's talk about some of those. So the product that you guys call American Cancer Society Cares,
Mhm.
maybe explain what that is and how that can be of benefit to the patients in this room right now that are watching you.
Well, I hope it is. I think that as we think about who's getting cancer, right? We're starting to see across the board people at younger ages with multiple different types of cancer: breast cancer, colon cancer, melanoma, thyroid cancer at younger ages. So there is a bit of a demographic shift that's occurring, and that speaks to also then generationally, not as a monolith, but that there are different types of information seeking behaviors that people use. One is the proliferation of technology across all generations. So, people who are 60s and 70s are using apps, but also we're seeing people in their 30s and 40s doing it, maybe a little bit more, maybe the same. But the idea is that technology as a resource to access information and then ultimately to connect with others is a common reason why people may use apps. If you think about you open your phone and you look at all the apps that you have, it tends to be that the ones people use the most either provide novel personalized information, right? So a banking app is going to give you your right information, or it's going to create a connection with someone else. So you imagine a social media app, you're connecting outside yourself to something else, right? So like connection and personalized information are common reasons why people use apps. And so we thought, well, why not use that to help people going through a cancer journey or a caregivers of someone who is. And so CARES, which is the app, is a free download in Google, Android, and iTunes. And I encourage anyone to follow along, download, and take a look. CARES is an acronym. It stands for Community Access to Resource Education and Support. And so the idea is community, that anyone can have access. So whether you're going to a large cancer center, small cancer center, access to resources. So that's really important. We have a lot of resources at the American Cancer Society that sometimes go underused, that people don't know that we have. And so really matching them to those resources is really important. But also, we know that many other organizations, like yourself, right, have really wonderful resources and connections for people to have too. And we want to see ourselves as a clearinghouse. That's how we've set it up, so that people can get connected, particularly in a zip code-based way. So if you're in Warrensburg, Missouri, where I grew up, right, or if you are in Ames, Iowa, or you're wherever, that you can see what's in your backyard that can help you. So that's really important. Education is really important because that's the E in CARES, because oftentimes people are trying to find what's the right information. You mentioned AI. We actually use something called semantic search as a type of AI to help you try to be guided towards what are you looking for. Because, Dick, unlike you and me, not most of the people we take care of didn't go to medical school and didn't learn 50,000 new words and didn't spend a lot of time in Latin and Greek to know our words. But the sentiment of what they're trying to ask is really important. So you might say, what is the cost of getting a mastectomy versus a lumpectomy? Let's say you're making a decision and the cost is important. Well, we might have indexed that article as financial toxicity. So if you didn't use that term, you might not find that page. People know this when they do searches on Google and other places. What semantics search does is, using AI, it tries to guess what you're trying to actually get at by thinking of other words that you're not using that maybe you would have if you would have been a doctor or something else. And so we've got that in the system in terms of CARES. And then lastly is the support part. And we know that there's a lot of value in people connecting with each other. So CARES does three fundamental things. Tailored content to you. So once you tell it who you are, 40-year-old woman with melanoma, well, we're going to give you content related to fertility preservation because of your age, related to melanoma because of your diagnosis, and maybe even related to the stage of care that you're in, newly diagnosed versus active treatment versus survivorship. So there may be an article related to survivorship with a melanoma, like how do you use sunscreen to a person who's had a Mohs procedure and has had something removed. The second tenet of what it does is to do a health-related social needs screen. We know, right, Dick, that in cancer outcomes, we say that 20% is biology, and the other 80%, like drivers of outcomes, the other 80% is the basics. So 20% is biology, that's the cells, what it looks like under a microscope, a scan, blah, blah. But the other 80% is the basics. And what I mean by that is the things that we as humans need. Love, support, connection, yes. A roof over our head, a place to stay, food, transportation. Those are the things. And what we know is that when people miss out on treatment, let's say they're going to get 6 cycles of chemotherapy for breast cancer. If they miss a cycle, it's not because they don't believe in 6 cycles. It's because one of the basics got in the way, right? A barrier to the basics got in the way. And at ACS, we've been focused, for 55 years on lodging. Our first Hope Lodge, which is where patients can stay for free who are accessing cancer treatment. We opened that first one 55 years ago. And what's so humbling is that over that period of time, the number of treatments, right, in cancer have gone like this. But the thing that has stayed rock steady during 55 years is people need help with lodging. Same thing with transportation. Last year, we gave 70,000 free rides to patients through our volunteer program. And so what CARES is really meant to do is match people to those programs. And then lastly, it's to match them to each other. So if you are someone who's gone through a cancer diagnosis and you say, I'm a survivor now, but I'd love to help someone else newly diagnosed, we have a matching program within CARES where people can connect with each other and help each other out.
And how does someone access it? You said it's as simple as going to download the app, and you just put in American Cancer Society Cares, and the app pops up.
That's exactly right. Yep. So you get your phone and you go to the store where you would download apps, and it's going to be free, and you look for ACS Cares. Yep. And you're going to find this really beautiful logo that has multiple colors on it. And the idea is it's really meant for everybody. And what you do is you tell us a little bit about who you are. Now, we protect your data. We don't sell it. We're not asking you for money. The purpose is to give you personalized recommendations. And what you're going to see is a home screen that has those recommendations in it. We do a standard health-related social needs screen onboarding. So we're going to ask you a bunch of questions about food, lodging, transportation, relationships, as to I connect you with services. So that's what it's meant to do. And then lastly, it's going to say, do you want to connect with another survivor? And we kind of took, Dick, a little bit of a like a dating app approach. You say what you're looking for. The person who's the survivor, who's a volunteer, who we train, we use an asynchronous online. So for any of your listeners who are like, wait, I kind of like that idea, go to CARES. You can sign up to be a volunteer. We'll send you an online training just about, how to respond to someone who's in distress, right? How do you not overpromise, right? You're not a therapist, right? But you are a navigator. How do you function in that role? Well, we'll send you that. And then what we do is use an algorithm to say, here's what the volunteer said they can help with and where they live, right? So if they live in Chicago and they had melanoma, then we might suggest to the newly diagnosed patient, hey, there's someone in your area who also had melanoma who's in the Chicagoland area. Or, right, maybe you're in Iowa City and you're going to go to Chicago to get a second opinion. And you're saying, I want to be connected to someone there to tell me, like, where do I go? Where do I park? When is traffic really bad? Because you realize that sort of tacit knowledge and experience is really important. I remember I was in clinic today, right? So I'll tell you a quick story. I was in clinic today. We have our cafeteria in the cancer center closes at 2:00. Now, if you're a newly diagnosed patient, you're coming here, you don't know that. And I remember walking out to my waiting room because there was a patient who was slotted at 1:45, who I was probably not going to get to be able to see till 2:30 because I was running a little bit behind. I like talking to my patients, you can imagine. And, it was about 1:45. So I went out to the waiting room and I said, I found them and I said, hey, you should probably go down to the cafeteria and get food before it closes because I'm going to be running behind. So this is me. What's interesting is they said, oh, we know that already, Dr. Kamal. I said, you know that already? How do you know that? I said, I was talking to my other neighbor here in the waiting room who kind of gave me the tips and tricks of how to be Dr. Kamal's patient at Duke University, right? And it was literally like, go get some French fries, before, because he's going to run about 30 minutes late. And this is when it closed, blah, blah. And that was kind of the moment where you realize there's a lot that we can teach each other, not Cancer 101, but about the experience. What should I keep in mind? What questions should I be asking? What should I be worried about? Is that normal? Is that abnormal? What's the difference between grade and stage, right? They said stage 2. Is that bad? What does that mean? I've never heard that before. And that we can be teachers to each other is another reason the app really exists, because people can text each other in the app without knowing who each other really is. So there's a level of anonymity, but at the same time, you can say, hey, here's me. Do you want to meet up at the Starbucks? So you have the ability to even take that relationship outside of the app if you want to.
Right. And as you pointed out, even in the name of the app, the CARES, is the resources. How does the American Cancer Society keep up on what's really happening with resources? Resources come and go, and
Yeah.
services go away, and new ones are added. How do you possibly keep up on that throughout the country?
Yeah, it's a great question. So one is straight from the app, you can call us with a button, right? If you're accessing the app on your phone, which most people do, a lot of people do, or even their iPad, you can just click one button and call the American Cancer Society. And we are 24/7, 365, have cancer information specialists, that's what we call them, on standby to talk to people. And so if you're like, I just want to use the app to call it, great, you can do that. Now, if you want to use a little bit more kind of a different approach, we have another technology term called an API. So it's like a window into something else. So we have a window into a database that another nonprofit keeps up. And in it, there's about 27,000 resources that they curate and keep up. We used to do that, and we realized others are actually better at it than we are. But what it'll do is it'll window into that. You put in, Warrensburg, Missouri, where I grew up, 64093. So if I put in 64093 and I have said that I have food insecurity, it's going to show me the food banks and food resources, nonprofits that are within 20 miles of the zip code that I put in. And all that happens within the app, either automatically because you put in that information, or from the app you call us and we go through the same process. We'll just have a human ask you those questions and do it for you, and then give you the results and either email it or text it back to you if you want.
And as you mentioned, one of the novel approaches is that within the app, you can have this buddy system,
Right.
or do you call them lay navigators, or what's the term you use
We
for a
call them community
volunteer
navigators. Yeah, yeah, community.
navigator?
Mhm.
Community navigator, is that what you said? Yeah,
That's right.
yeah. Are you finding that to be attractive? It's relatively new. Are you getting enough volunteers to serve as the community navigators? Do you have more people asking for navigators than you have navigators, or
We do.
how is that
We do. Yeah. The
developing?
short answer is we always want more volunteers. I think when they come on board, they stay because they kind of like, because the interactions are short. It's like getting a text message from a newly diagnosed person who says, "I'm overwhelmed. Where do I start?" And you can say, "Hey, this is where I started. Here's what helped me. Blah blah blah." So it's not hours long of conversations, but we are always looking for community volunteers to join us as community navigators, because the demand is way more than the supply right now, and we can get better at getting to personalized matches when we have more people, right? So we're going to need a survivor with melanoma in Chicago to be able to match to a person with melanoma in Chicago. And so, we haven't put a lot of media behind it, if you will. So it's kind of a program that is growing organically. So part of the roadshow that I do, join podcasts and other things to do, is really to invite people to do that. And I found that for a lot of people who've gone through a cancer experience and want to give back, they're kind of looking for that, like, but how do I guide someone a little bit? Not as a clinician, but use my lived experience to someone else's benefit. Where can I do that? And that happens informally all the time, right? Someone might text you, a
Mhm.
neighbor might reach out to you, and that's great. Um, but this is one of those opportunities where it's kind of all collated into one space, and you can decide who you want to get matched with or not. So you could say,
Right.
that part of the experience wasn't great for me. I don't really want to talk about that with someone. So we're going to stay away from that topic. Here's the topics I do want to talk about. So you have some agency yourself as a navigator to do that.
And obviously, it's the umbrella of the American Cancer Society,
Right.
probably the most respected name in cancer in the United States and the world. So that has to give both the patient and the navigator comfort in knowing they're doing this connection under your umbrella.
Yeah, we hope so. We've had a lot of really great responses, both from community navigators and from patients who've said, this is really wonderful. And listen, you were talking about programs we've had before. Really the way people connect with each other for support, peer support, has also morphed over time, right? ACS used to do a lot of programming around in-person support groups. And then what we found is that actually cancer centers and health systems are really good at doing that themselves. So we started providing technical assistance. And then we've largely moved out of that space because people who want that can typically find that resource in their community. They don't need us to do that. So as we've shifted away from that, we used to then have chat rooms, where people could come in and kind of chat like that. And then we realized that, gosh, cancer is such a personalized experience that as much as it is, if you're a 40-year-old woman with melanoma, that the 70-year-old man with lung cancer, there's some overlap, but cancer is getting so personalized that maybe you really do want to talk to another 40-year-old woman with melanoma because you're worried about similar things and so on. And so that chat rooms are oftentimes not good because it's kind of everyone sitting in a room all chatting at the
Mhm.
same time, that's not the best fit for everybody. So we've really even transitioned away from that approach to a bit sort of personalized, one-on-one, asynchronous, on your own time, like how people text message, right? They don't, sometimes they send a text and someone answers 3 hours later, right? And if you want synchronous communication, you might call that person because the text might not happen live, but you're still getting your point across and someone's going to respond. So it kind of takes that approach.
You also have two other products, and I think are they each apps as well?
Yes, they're web apps. So yes,
Web apps, yeah. So, the ACS Acts,
yes,
and, which is, about clinical trials.
yeah,
Maybe let's touch on that next.
yeah.
Clinical
So
trials obviously so important because that's how
important.
we advance cancer care, is to conduct clinical trials to in order to prove or demonstrate is better than what we've been doing, we need to do clinical trials.
100%. I'd say, cancer is big. It's a big topic. It's a big, hairy topic. It's a complex topic. But in many ways, right, I think, Dick, that cancer's has become smaller. And what I mean by that is, oncologists, radiation oncologists are much smarter than medical oncologists. But, we're all pretty smart. But what we're not good at is marketing. And what I mean by that is, when we first found lung cancer and we looked at it under a microscope, we described it by what the cell looked like. So when the cell was small, we called it small cell lung cancer. And then when we looked under the microscope and the cell wasn't small, us being not great marketers, as oncologists, we called it non-small cell lung cancer, right? So that's about as creative as we can get. But all kidding aside, cancer used to be one thing, then it was two things, then with mesothelioma, it was 3 things, 4 things, 5 things. Today, you could argue maybe it's 50 different things. Let's just say, for argument, it's 50 different types of lung cancer described by a genetic or a molecular alteration that is either describing that cancer or was the fuel source by how it grew, what made it grow. So if that's the case, and there's 50, let's say there's 50, and you've got number 47. Then for you, the treatment we give to number 1 through 45, 46 may not be the right thing for you and your number 47 lung cancer. So where is that potential treatment that might help lung cancer number 47? Very likely it's in a clinical trial. Now, what's interesting is, right, when you look at clinical trials, for a lot of people, it seems like, okay, sure, of course. But the data would show, including from the American Cancer Society, that less than 10%, about 7%, so 7 in 100 people, adults with cancer who are eligible for a clinical trial, actually enroll in one. So potentially 93 people are missing out on the potential opportunity. So, why is that? Well, let me first give you the so what. So what? So what is the possibility? Well, let's look to our colleagues in pediatrics. We know that in kids with leukemia, that 20 years ago, the mortality rates, meaning the chance someone's going to die, was probably about 4 and 5, 80%. And now today, the chance of survival from pediatric leukemia 20 years later is 80%. So we flipped the outcomes completely on its head, from 80% death to 80% survival. So the question we would ask each other is, why? How did that happen? And in 20 years, you must have developed, 40 more drugs. Is that what happened? Well, there are new drugs now for sure. But the other thing that really happened is, for pediatric leukemias, we went from about 20% of those kids being in clinical trials to now close to 90% of those kids. So what we see is, when you solve for and increase the clinical trial enrollment rate, it's not by accident that survival rates can follow behind it as well. We see a script for that for our kids. So the question is, could we get something similar like that in adults? And I think we can. It may not be exactly the same, but there's a path there. When people ask me on an airplane, if I'm sitting in an airplane, they sit next to me and they see the, the swag that I've got on, and they say, oh, you work for the American Cancer Society, oh, you're a cancer doctor. When are we going to cure cancer? Dick, to me, I say when more people are in clinical trials. I mean, to me, I think it's a pretty simple answer. Now, how we get there is not simple, though. So let me talk about the ACTS program. So ACTS stands for Access to Clinical Trials and Support. And what we realized is that people don't access clinical trials for a couple main reasons. Not all of them, but the main reason. So the first is going to be around education, familiarity, understanding of clinical trials. And listen, let's all recognize that this country and other countries have had a mixed history with how we have handled ethics and compliance in particular populations. We have to acknowledge that that is true. And that the distrust of clinical trials by some people, some folks, some historical things that have occurred are understandable. But we have also gotten to a different place, I would argue, than where we were before. But that message may not get out to everyone. And so the opportunity to talk about what's the modern approach to clinical trials, the modern approach, ethics, informed consent, and those things, which are really important. We need to talk to people about that and then let them decide if they feel comfortable with those updates and things that we're doing now. So that's the education part. ACTS does that because the input into ACTS is either through our website at cancer.org or by calling our 1-800 number, 1-800-227-2345. And then what we'll do is we'll start on that education piece. What do you know about clinical trials? What would you like to know? What would be helpful to know to help you make a decision? Because as the American Cancer Society, as you mentioned, we've been around a long time. And the only dog in the fight, if you will, that we have is the best thing for the patient. So I don't care about a particular cancer center, a particular drug manufacturer, a particular drug. I don't, like to me, whatever's the right thing to do is the right thing to do. So we can kind of be Switzerland, if you will, right? I just want people to understand whether a clinical trial can benefit them. And if so, then be able to go forward in the process. I'm not interested in one company's clinical trials versus anyone else. So that's important. So the second thing we do is then recognize within the ACTS program that, again, remember I said that 80-20 rule, the biology and the basics, that these basics show up in clinical trials too, which is maybe I have to stay overnight and get a CT scan the next morning or a blood test 18 hours from now or 12 hours from now. Well, where am I going to stay? And I can't pay for a hotel to do that. And many clinical trials won't because of very complex reasons. And so, maybe I need help getting there, et cetera, et cetera. So all the things I talked about before show up again here in this world of accessing clinical trials. And so what we do in the ACTS program is again, you'll hear this again, standardized assessment for health-related social needs, food insecurity, lodging, transportation, et cetera. And then we're going to connect people to services in a very similar way, as I mentioned, within CARES, so that those logistical barriers are hopefully largely addressed. And then the last part is, but which clinical trial, Dr. Kamal, might be right for me? Now, this is where AI has been really helpful in the cancer space, is everyone is different. Their pathology, their cells are different, their situation demographically, their comorbidities, meaning other diseases they may have, are all different and unique. And, AI has this amazing potential to put all that data together, all those things in their medical records, and really kind of then take all the dozens of thousands of clinical trials that are out there and start to kind of put matches together, right? And that's exactly what we're doing. So if we educate you and you're like, okay, I want to go forward. And if we talk to you about the potential logistical barriers, you're like, hey, I think we can kind of solve for them. Then the question is which trials are out there. And what we use is actually a third-party service that uses AI. We transfer you to them and they have a navigator talk you through which medical records do we need to grab. And by we, I don't mean HCS. It's really another organization that knows how to do HIPAA and all the things that we would need to do. Bring all that in and then give you. And so far right now, we launched this program really just a couple months ago. We've had about 1,300 people call us, but importantly, we've led to about 2,500 different matches. So every person averages about 2 different trials for them to consider. And we can run it again and come up with more. Doesn't help to have 10 things maybe to choose from, but we're starting to see that really kind of provide a service. Now, again, as the American Cancer Society, what's unique about us, I would say, is that we address all cancers. Plenty of really great nonprofits in the field that are hyper-focused on a particular cancer, and that's helpful too. We can, though, also think about all the cancers and scour all the trials to see if there's overlap and other things too. And really then what becomes important is you feel empowered and familiar with about a trial. We understand what the barriers are, and then we get you matched over, and then we kind of close the loop and say, well, what else can we help you with? And what we're hopeful for is that we help kind of get more people to that right care by participating in the program.
Yeah. I mean, it's a noble effort, and I'm going to ask a couple questions, and it might sound critical, but I would think that number one, the patient might not have all of the information that would be necessary to make. I mean, it's
Totally.
not, they may not know
Yeah.
the 50-page neogenomics report on exactly which version of lung cancer they have.
Right.
Second, I wonder whether says there are other ways of doing searches, but sometimes the trials are temporarily closed,
Sure.
or the expense of going halfway across the country or all the way across the country
Sure.
just doesn't make it feasible.
Sure.
And I just, those would be concerns I would have, as but obviously fine tuning it, and the fact that there is a human being that helps
Yes.
determine what is the information about your lung cancer that we determine whether you're eligible. But do you get people that there is a clinical trial, but the idea of taking off work and finding a babysitter and flying to New
Yeah,
York City or Texas isn't realistic.
we do, and I think that I think really what we're trying to do is empower people, to think about trials. Maybe we give them a couple matches, but they go back to their cancer center and say, hey, and I think, some cancer centers have their own trials and have a mechanism by which to do kind of what we're talking about.
Mhm.
But in a lot of the work we do, we're also trying to be a bit of the sort of the safety net for folks who don't, right? So we're not trying to replace anything, actually. I think it's very additive. But you may go and folks might say, and we hope to partner with cancer centers of all sizes who might say, oh, we're leaning on the ACSX program to be our clinical trials education and matching engine because we just can't build that infrastructure ourselves, or maybe we would need a part of a person, a part of a part, right?
Mhm.
And so really it becomes a bit of a co-op, if you will, that can work. And for us, the program is free to the people who use it. It uses
Right.
donor dollars. So in some
Right.
ways it becomes a national resource that everyone can tap into if they need to. But listen, if you're getting that great support from your own cancer center, keep doing that, right? I mean, we want you to find, because we're all using the same database of information, right? Um, but I think for some people, having that navigator spend some time with them, talk through. I know you've got 50 pages. The one we really need to see is the one that's titled the NGS. Look for the term NGS, and it's going to have an executive summary. Bring that. Let's take a look at that and use that one.
Yeah, yeah. You make a good point, though, that research is being done else in community cancer centers. So
Totally.
our cancer center is a comprehensive community cancer center, but we have a grant from the NCI to do the community oncology research program. So we have 60 clinical trials open, but
Yeah.
it is good to have patients also be aware of all of those clinical trials and to advocate for it, because as you point out, if you're not doing clinical trials, you're not advancing cancer care. And to have a center with 50 different clinical trials is really a demonstration of the quality and commitment and the time and effort that is being put into not only treating patients, but advancing cancer care.
Absolutely. And I think whatever we can do, to get that 7% number, that's pretty low, right? I think most people I share that with,
Yeah.
they're like, really? Yeah. Listen, it's and I think, there had been this idea that clinical trials are only meant for people who are sort of out of other options. And I think right now I really position it less about sort of experimentation for experimentation's sake and more about access to innovation, right? Is that the newest, greatest thing, and we don't know fully if it's going to work, right? So let's give that caveat. But where it's going to show up first is going to be in a clinical trial. And so if you're saying, I want to try that thing,
Right.
that ends up being the place to do it.
I'm also excited that the fact that some clinical trials now are really geared toward reducing toxicity. There
Yes.
are some cancers where the cure rate is so high that really the appropriate research, we're not going to find a better research when a better form of treatment if you're almost at 98% success rate, but we may be over treating some cancers. So it's exciting to see that some of the research protocols may actually result in better overall health of patients by
Yeah.
actually reducing treatment.
Yeah.
Um, I'm doing a time check because I want to leave a lot of time open for Q&A. There's one other program that I would like you to talk about. And we know right now that in the United States, for example, about 45% of all cancers are caused by what we call modifiable risk factors.
Right.
It's our lifestyle, and that if we didn't invent a single new cancer treatment, but we utilized all the knowledge that we had to change our lifestyles, that we could eliminate almost half of cancers and that we could eliminate almost
Yeah.
half of cancer deaths. So you also have a program for patients,
Yes.
for the public, really. Doesn't
Yes.
have to be a cancer patient. It could
No,
be someone
no, no.
who's never had cancer and wants to avoid having Cancer Risk 360.
Yeah. So, imagine this amazing moment in time where we're saying exactly what you said, Dr. Deming, which is maybe about half cancer modifiable risk factors. So everyone who's listening is like, well, great. So what do I do? And that's fundamentally where we want people to get to, is a place where they can take, action in the way that makes sense for their life. And so Cancer Risk 360, you just Google it. It's a free online. It takes about, on average, 7 to 8 minutes for someone to take it. So it's comprehensive, but it doesn't take 30 minutes. And it doesn't require your medical records or anything like that. We don't ask any personal information that gets saved to us. It really is like an online calculator, if you will. And really, we kind of ask you a little bit about your family history, how you live, and so on and so forth. And as you go through those modules, really the idea is that at the end, there is a sort of a personalized recommendation sheet. And what it's going to do is not only say something like, hey, Arif Kamal, you should consider eating a few more servings of whole grains a day. It's going to tell you the why, and it's going to link you to an article, ours or others, that kind of gives you what that means. Because, listen, we know that the majority of people who get colon cancer under the age of 50, so that would be young age, don't get enough whole grains. And we believe that whole grains and fiber has a protective effect. So now the question is, okay, that's great, Dr. Kamal. What is a whole grain and how many do I eat, right? That's the purpose of Cancer Risk 360. Is that you can start to then create a grocery list, a activity list, some sleep tips, right? Some relation tips, some screening ideas, and even a suggestion for whom potentially there's benefit for germline genetic testing. Because what we know is that about 1 in 10 adults in America, just 1 in 10 adults, has a compelling enough family history, right? Aunt had this, mom had this, grandma had this, whatever that is, to put them at increased risk, meaning more than average risk. And so when we think about, let's say, mammograms, for example, right? The American Cancer Society, we were really one of the first to decrease the mammogram age to 40 for sure. And so what we say is, starting at the age of 40, you should talk to your doctor, and certainly by the age of 45, you should start. But the thing I worry about, right? What if you're 30 and you're thinking, well, what am I supposed to do? Well, the answer is you take Cancer Risk 360. And what you might find is, based on the family history you put in, it might say, hey, based on your grandma having ovarian cancer and your aunt having stomach cancer, you might want to consider talking to your doctor about getting genetic tests, because if the doctor finds something, we might actually start your mammograms at an earlier age, maybe even use MRI or ultrasound or something different. And so you can create a tailored plan, maybe even different than the guidelines, because I think it's really important. The guidelines we put out at the American Cancer Society and others put out too are for 90% of people, but not everybody. And so the question is, are you in the 10? Or are you in the 90? The only way to really know is to take a tool like Cancer Risk 360.
Right. So we're going to open up for questions. So we have a live studio audience in the room here, so they get first dibs on questions. But if you happen to be watching us right now on live stream, you can use the comment section of the software you're using to watch us this evening to ask Dr. Kamal a question. So let's start with the room here. Poon, you're up first.
Dr. Kamal, I'm curious, what is the American Cancer Society doing to help folks in Iowa? We're number 2 in the nation with our environment and our water system.
Yeah. So, American Cancer Society is a big organization, and so I'll let Dr. Deming and others speak to definitely the policy things that are happening in CAN. And I recognize particularly the role of radon as it relates to lung cancer in your state. We included radon education and assessment in Cancer Risk 360. I did it because I remember a conversation Dr. Deming and I had. That's true. You told me about that, and then I remember then going to the EPA maps, and I grew up in Missouri, but particularly in the upper Midwest, right? As you go Iowa north, you start to see higher. And so what we have in Cancer Risk 360 is it's optional, put in your zip code, and we'll actually map it to the EPA map and show you what it's like around you. And when we started putting this in, to your guys' credit, when we started putting it in Cancer Risk 360, people are like, radon, what does that have to do with anything, right? And so we ended up educating a lot of people. We've had 70,000 active users. So that's 70,000 people who learned about this who may not have known it before. The other thing is, listen, Points of Pride, our Hope Lodge, in Iowa, many of the grants and programs that we do to improve how care is delivered at the health system level, these aren't research grants. These are quality improvement grants to cancer centers and health systems. Many of them are coming to Iowa as well. And I think that there's a lot for us to learn, particularly on the can side, Dr. Deming, if you want to talk to about the importance of advocacy, particularly at the state level, for awareness around some of these topics.
Right, right. So there's an organization that walks the walk like the American Cancer Society does, and as Dr. Kamal said, some of it is the work they're doing with individual patients, whether it's helping find them a ride to their treatment, helping them provide housing at Iowa City, or also American Cancer Society provides grant money to Above and Beyond Cancer that operates the hotel program, so that patients who are getting care more than 50 miles away in a city that doesn't have a Hope Lodge, which is every city except Iowa City, they get care. So there's a lot of personalized, but then Dr. Kamal makes the point of public policy, and I think that's what you're alluding to, is how do we systemically change. The American Cancer Society has a sister organization called the American Cancer Society Cancer Action Network, which is all about public policy and advocacy. So I happen to have the honor of chairing that nationwide. So they not only do work in Washington, D.C., regarding federal legislation and federal policy, but they have representatives in all 50 states, including Iowa, where they help work on public policy initiatives, such as expanding Medicaid so that more people have access to care. But they are involved in looking also at the particular risk factors in Iowa that may include not only the conventional modifiable risk factors, but things like radon and also the chemicals that we're exposed to in the environment. So the American Cancer Society is playing a role in Iowa as it does throughout all 50 states. Next question, Angelina.
Yes, in regards to the Cancer Risk 360, so say like a cancer survivor like myself, breast cancer, did the genetics and found out it wasn't genetics that I got breast cancer, even though my grandmother had breast cancer, my mom had ovarian cancer. Is there in the questionnaire to help somebody as a cancer survivor to look for foods that would best keep me as a cancer survivor, or to be aware of potential other cancers that could be happening for a person as a breast cancer survivor, if that makes any sense?
It does. It makes great sense. And so I'll say this, the caveat is it's not yet optimized for cancer survivors specifically. So that's the next version we're going to build. And I'm glad you brought it up, because there's 18 million of you and growing, right? And so we want to have a tool. Now, I would say in the meantime, I think the principles that are in there around servings of whole grains, fruits and vegetables, and I'm saying it very quickly as if it's not important. There's a lot of science behind every little thing I'm saying here. So I really want people to go peruse it and understand, like, red meat, right? Fiber, whole grains, fruits and vegetables, some of these things related to sleep, exercise, weight, right? We know, for example, and this is not a judgment, this is just science, that when we are, as oncologists, when we put people through treatment, let's say for breast cancer, weight gain is not uncommon. We give people steroids, fluids, we might cut into their routine as it relates to exercise and things like that. But what we do know from good evidence is that if there is weight gain during the course of treatment that doesn't go away, meaning for whatever reason that the baseline weight of that woman gets higher than where they started, that is a risk factor for the cancer coming back, a relatively important risk factor. And so what we highlight in there is that, again, not shaming anybody, not anything like that, but just pointing out that here's some ways you could think about getting that weight back down to what might be my fault because of what I gave you in terms of treatment. But listen, the best part is let's just be aware of that and make maybe potentially different decisions. And I'll tell you, it can be something like, you go and instead of ordering a hamburger, you get a chicken sandwich. And, as people think about that, there may be many motivations for why. I just want to bring the concept of cancer and cancer recurrence to kind of the front of mind about why you might go, well, I had a burger this week once already. Maybe I will go with the chicken sandwich because I remember Cancer Risk 360 said, get that red meat consumption to like once, at most twice per week if you can. And so those start to become part of your working memory in terms of how you make decisions, grocery stores, restaurants, and other places.
Great. Next.
Yes. Hi, Dr. Kamal.
Hi.
So I have two questions.
Okay.
The first one is like in terms of ethnicity, because I'm Southeast Asian. And so the question being like, we have like probably more insulin sensitivity or resistance with the
Sure.
biomarkers and in the epigenetics.
Sure.
And so wondering, does the cancer, I think 360 tool, does that show like for somebody who's, what would be the carb content to have, or, you know, what are the areas where we could cut back more on sugar?
Sure.
And I know that there have been tests, like maybe there was a trial done on, you know, a Caucasian versus Southeast Asian, and,
Sure.
you know, the higher for both of them, the Southeast Asian gets more of the visceral fat and the insulin sensitivity than the Caucasian. So in that aspect, what would be, you know, the guidelines for, you know, the consumption of whole foods and less sugar and more exercise from that context?
That's a wonderful question. The short answer is we don't, based on that type of ethnicity, give personalized recommendations right now in the current version. And this is, you know, kind of a living thing that we continue to update and modify. Right now, we do look at ethnicity like Ashkenazi Jew and some other sort of like very high risk. We kind of hone in on that. But to your point, I'll say a couple things. One is that we do point out not only sort of the grain part, but we also point out the ultra processed food issue. And ultra processed foods in South Asian diets, but in other places too, can be pretty common. And so we point out that there is a relationship between ultra processed foods. Now, how does one define an ultra processed food? I think, you know, if you look at a label, you know, when I talk to my colleagues, and there's differing sort of working definitions of this. And clearly, the current administration, the federal administration, is interested in this issue. So it'd be interesting to see what comes out. But I kind of use a rule in my head. I call it the sort of the 5 ingredients rule. And I don't mean if you're making a homemade meal, that's a different thing. But you pick up a package of a thing and you look at it. I dare anyone to find a real 5, right? The first 4 or 5, I think, is food items. After that, you start running into preservatives, shelf stabilizing agents that fundamentally make it better for the manufacturer, but not necessarily for you. But I'm going to point out, so I just want to talk about ultra processed foods for a second, but you asked about Southeast Asian. So let me talk about that for a minute. I think one of the things that we find oftentimes is the diet that people in South Asia eat back home versus what they eat here, and the richness of the calories can change weight. So I'll just talk about my mom for a second. My mom immigrated to this country in the 1970s, probably 90 pounds soaking wet. I think by the time she'd eaten the Western diet, which was still very Bengali based because my family's from Bangladesh, you know, got her to a number that was, I think, closer to 150, 160. Now, that for her was a significant weight gain, right? For someone who's lived their entire life kind of 90, 100 to get to there was significant. And so highlighting not only insulin resistance, which we in Cancer Risk 360 point out the diabetes and insulin resistance as a risk factor for cancer. So we call that out as a specific thing for people to know. And that might change how they approach cancer screening or talking to their doctors. But we also point out this issue of, particularly for women, postmenopausal weight change. We know very accelerated postmenopausal weight change can be associated with cancer, but that there are 13 different cancers associated being at an unhealthy weight, such that, to your good question, if you were South Asian, and let's say you're a 50-year-old woman, maybe you're a 6-year-old woman, postmenopausal, you know, gained 30 pounds in the last 5-6 years, diet change, whatever, you have a little bit of a family history of ovarian cancer or brain tumors or some of these other things that are a little bit more weight sensitive, and you know you've got some insulin resistance, right? I want people to take Cancer Risk 360, put that story together, and go to their doctor and say, you know, I'm wondering if I should be doing something different, either from a screening perspective or from a lifestyle perspective, because there's all these little signals that I want to share with you that I think are salient to know about my family history, how I live, how I lived before, how I live now, that might make our sensitivity to a particular symptom, right, be different, so that rectal bleeding maybe is not a hemorrhoid bleed, right? That maybe a mass felt in the breast is not cystic, right? That you have a different threshold for worry when you start putting these pieces together. So I really appreciate your question. I think we need to get to more finesse around particular populations, but I would say for right now, take those nuggets of information that are salient to you and bring them up to your doctor, because you might need a different plan than what the guidelines might say.
Great question, Pearl. Thanks. Ron.
Hi, doctor. Well, thanks for being here. And just kind of one question. There's been a lot of headlines about cancer research being cut.
Sure.
And wondering how that's impacted the American Cancer Society, and if you're able to come up with ideas to offset that.
Yeah, that's a great question. Listen, it's a big deal. So I'm glad you asked it. And Dr. Deming knows this too. This is a big deal. I, as a researcher, was funded by federal funds. Many people, right, are really reliant, because what federal research dollars do is allow for a researcher to be agnostic to who the winner is going to be. Right? If you are, right, people have argued, well, let pharma companies do the research. Pharma companies have particular outcomes they want to have happen, right? And they do it with integrity. That's not it. But they're going to study their drugs, and these people are going to study their drugs. The question is this person's drug versus this person's drug, how do they match? Well, these two companies may not want to do that trial. So we need to have others fund that, because it's for the benefit of Americans to understand not who's the winner, because the winner needs to be the patient, not this company or this company. So that's a lot of the research that's funded by the federal government, of things that others may not or can't or won't do. And to your point, what's been proposed is potentially a 40% cut to the NIH and the NCI, maybe a little less. I think really the ripple effect of that is one where we're going to feel that for decades, because you're going to interfere with people's careers. There's people who are going to say, I don't want to be a scientist. It's too hard. Because let me tell you right now, the reality is when I've written federal grants to the National Cancer Institute, which is the largest institute within the NIH, the chance that I get one of those grants that's $1 or $2 million is probably about 9 to 10% currently. If you cut that down by 40%, then that number gets to what, 4 or 5%? 1 in 20 good ideas gets funding. What happens to the other 19 researchers? They might just say, forget this. I'm not doing this anymore. And they might leave the field. That's what our worry is. So your question of what we're doing. As Dr. Deming mentioned, ACS CAN, our Cancer Action Network, is arguably, or not arguably, the most powerful voice in the halls of Congress and the federal government and the halls of state capitals to bring this attention to policymakers and lawmakers. Because at the end of the day, cancer cures are not a political issue. They are a human issue, right? And the only way we get there is by doing research. And a lot of what we're trying to remind policymakers and lawmakers is this is not a partisan issue. The chance of getting cancer in one's lifetime as a man is 1 in 2, as a woman is 1 in 3. There's nothing political about that. It's just omnipresent. It's everywhere. And so we're reminding folks that, that we can all agree. There's many things we can disagree on for whatever reason. The thing we can agree on, we can absolutely agree on, is that we need to continue to fund cancer research. And that's what's made America, the leader in cancer research across the country. And the unprecedented number of new drugs that have been approved have really come from that. And so what are we doing? A lot of effort in advocacy, a lot of public campaigns, and a lot of grassroots campaigns that will, as Dr. Deming will tell you, exactly how you all can raise your hand and be part of the voices and the stories that we collect to share with lawmakers, to remind them that these cuts have consequences, and that is the faces of people who could not access a thing that we could build if only we fund that research.
Great. That we're going to have to end it on that. I know we got more of time. Okay. Our guest this evening has been Dr. Arif Kamal, the Chief Patient Officer for the American Cancer Society. Arif, thank you so much for being our guest. Thanks, and we will definitely have you back again. If anyone watching this program knows someone else that would benefit by watching it, good news is this program will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also at the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.